Good morning. I'm Dr. Deepa Sir in Department of Pediatrics at Lakshmi Narayana Medical College. Today's topic of presentation is approach to a child with developmental delay. So let us see the facts and the figures first. So developmental delay is seen in 5 to 10% of children. And the global delay is seen in 1 to 3%, among which 2 to 3% are mild to moderate and one-third are severe to profound. And autism spectrum disorder is seen in 1% of children. Next, let us see the general principles. So, development occurs in a cephalocaudal progression. It is a dynamic process. Occurs over a trajectory. It need not be consistently smooth or even. Rapid acquisition of new skills followed by a period of practice and consolidation. It is a plateau phase. It depends on the neurological maturation as influenced by external factors. Other rules are each child, the development of each child is unique and they develop at their own pace. Two children born on the same day may learn the skills several months apart. It is a dynamic process. Assessment at any point in time is merely a snapshot of a bigger picture. It is interpreted in the larger context from conception to the present. When skills do not emerge as expected or on a broader schedule, it is of concern. So, what is the above milestone and what is the age of attainment? So, this is an image of a child playing with the mirror. This is known as mirror play. It is seen at 6 months of age. So, what is developmental delay? Developmental delay is a failure to achieve age-appropriate milestones, and often there may not be a delay in all preterm children. They would catch up transiently, depending on the physical illness, whether the child was hospitalized or any illness, and the lack of opportunity to learn. Let us see some terminologies like developmental delay, developmental deviance, and developmental dissociation. So, what is developmental delay? Developmental delay is significant delay more than 2 standard deviation lower than the mean on age appropriate standardized testing, or delay in more than 2 major milestones. Developmental deviance, it is the acquisition of milestones in a sequence that is different from usual. Okay, some children may start walking even before crawling. Okay, and that is an example. Another one is developmental dissociation. It is the discrepancy in the developmental rates of different domains. So, predominant motor delay it is seen in a child with neuromuscular disorder, like any myopathies, neuropathies like the muscular dystrophies. Significant language delay is seen in deaf mutism. Deaf mutism is the child is having any hearing problem, he may start speaking late. And language and social milestones comes and it is seen in pervasive developmental disorder. So, what are the warning signs? Let us see. First, in physical. In a 5 months old child, a child who does not support his head well or does not bring objects to the mouth. In a 7 months old child, he does not reach for objects or does not roll over. And next is for a 9 months old child who cannot sit on his own. In 1 year, he can crawl or stand with support, and at 18 months, the child can walk independently. So these are some physical warning signs. The gross motor milestones and the fine milestones. So what is this image? So this is the image of a child sitting in tripod posture or sitting in support, and it is attained at 6 months of age. So let us see some warning signals in the cognitive domain. A 1-year-old child who is not searching the hidden objects, no gestures or pointing. So normally in a 1-year-old child, when we point toward when they find any interesting objects, they point toward the object. Next, in a 2-year-old child, a child who does not follow instructions or does not imitate. This is a warning signal in the cognitive domain for a 2-year-old child. Next warning signal in the social milestones. The child does not smile at people by 3 months of age, does not laugh or squeal by 6 months. No affection for caregivers by 7 months. The child does not play peekaboo by 8 months and no back and forth gestures by 1 year. So these are some warning signals in the social milestones. Let's see the warning signals in the language milestones. A 3 months old child does not babble. A 7 months child which does not respond to sound. A 1 year old child does not say a single word, and a 2 years old child who does not say two-word phrases or speaks only less than 15 words. So these are some warning signals in the language milestone. So what are the other red flag signs? A male child not walking independently by 18 months. So by 12 months, the child will start walking independently, and by 15 months, the child can run. So a child who does not walk independently is to be taken as a red flag sign. In early handedness, normally early handedness is seen in normally develops at 3 years of age, but the child, due to having some hemiplegic cerebral palsy, he can have early handedness by 12 months. Next is the child being excessively floppy or excessively stiff. Yes, seen in cerebral palsy. So red flag signs, like when a child is excessively floppy or excessively stiff, attaining early head control or having opistotonic posturing, having abnormal startle, the child is walking on toes, seen in diplegic cerebral palsy, child is showing over sign. It is climbing upon the when you ask the child to squat and ask to get up, he will be climbing on his legs and then stand up. It is seen in it is seen in Duchenne muscular dystrophy. Next is movement disorder in a child less than 1 year of age. So what is the above mentioned and what is the age at which is attained? It is a child showing standing with support. It is seen at 9 months of age. So let us see some terms. Global delay, it is a delay in two or more domains. Specific delay is delay in a single domain. Syndromic means it is a distinct clinical phenotype, dysmorphic features or congenital anomalies in a non-CNS organ systems. Non-syndromic is intellectual disability being the sole discernible clinical feature. So let us see some causes of global developmental delay. They can be divided into prenatal, natal, and postnatal causes. Prenatal causes account for 60 to 75% of the causes for developmental delay. And the genetic syndromes, example Down's, Fragile X syndrome, Rett syndrome, Angelman syndrome, and mucopolysaccharidosis. Cerebral malformation seen in neuronal migration disorders. Right? Corpus callosum agenesis. Next is metabolic causes seen in phenylketonuria, multiple carboxylase deficiency, and urea cycle disorders. Endocrine causes is hypothyroidism. So hypothyroidism is a common preventable cause of mental retardation. Next is neurocutaneous syndromes. Example, tuberous sclerosis and neurofibromatosis. Infections like torch infections and toxins due to maternal alcohol consumption. Just perinatal causes, they account for 10% of the etiology of developmental delay seen in hypoxic ischemic encephalopathy. Since postnatal causes account for 1 to 10% of the causes of developmental delay. Causes may be due to neonatal meningitis, trauma, stroke, or environmental causes. In common, most common causes could be cerebral malformations, genetic syndromes, HIE, and psychosocial deprivation. So, what is the objective of doing a developmental assessment? So, it is to identify the child is having a developmental delay and categorize and classify whether the child is having a syndromic or a non-syndromic delay or a global or a specific delay. Okay, a specific delay means any delay in a single domain. To search for a possible etiology, what could be the cause, whether it is prenatal, perinatal, or postnatal causes. It is to arrange for appropriate rehabilitation services, we have to identify a developmental delay. And to counsel the family regarding the possible diagnosis, recurrence risk, and complications, and also the prognosis of the disease. And is to address the comorbidities, which may be medical and psychological. So we have to After taking a proper developmental history, we have to calculate the developmental quotient at the end. So it is calculated by the above formula, which is observed age of attainment by average age of attainment into 100. If the developmental quotient is less than 70, it is termed as developmental delay. So what is the image showing? What is the above milestone and what is the age at which it is attained? This is a child doing bare walking. Okay, walking on all four limbs with abdomen off the ground. It is seen in 12 months of age. After identifying a child, we have to take a proper history which should be detailed. So, we have seen many causes like antenatal causes. So, in that, we have to rule out whether the mother had any complications like GDM, PAH. Any diagnosis was made antenatally using the soft markers like Down syndrome. History suggestive of intrauterine infections. The mother had a history of fever with rash or post-auricular lymphadenopathy. Any exposure to alcohol or drugs. The complications during delivery, like prolonged labor, any birth trauma. Next, history suggestive of hypoxic ischemic encephalopathy. Whether the baby had any neonatal jaundice or seizures in the postnatal period. Okay. In, whether any routine test like routine hearing test and newborn screening were performed or not. In the family history, we ask whether it is a consanguineous or a non-consanguineous marriage. There is any family history of developmental delay or any syndromic features. History of abortion, any previous neonatal or infantile death or history of sudden infant death syndrome in the family. And whether the child or any of the family members are having any abnormal odor of urine, whether the child had any abnormal startle reflex, any chronic illnesses in the child. Because chronic illness can lead to malnutrition, which in turn will cause developmental delay. Okay, which is correctable. Next is any possibility of psychosocial deprivation. Next, we have to ask history which is suggestive of pervasive developmental disorders with poor eye contact, solitary play, repetitive play, likeness for sameness, inappropriate social interaction. And next is we have to ask whether the child had any comorbid conditions like the eyes, any vision difficulties, any squint, nystagmus in the ears, whether child is having any hearing deficit. Next in the CNS, asked about any seizures, any feeding difficulty, behavioral disturbances. And in the general examination, short stature could be seen in Turner syndrome, William, Cocaine, and Sickle syndrome. Obesity in Prader-Willi syndrome, Beckwith-Wiedemann syndrome. Microcephaly in Torch syndrome, Torch disease, Torch infections, chromosomal and peroxisomal disorders, Rett syndrome. Macrocephaly in Canavan syndrome, Alexander and Tay-Sachs disease. Hypertelorism is widely spaced type seen in fetal Hayden-Toyne syndrome. Hypotelorism and maternal hyperphenylalaninemia. Depressed nasal bridge in Down syndrome, fetal alcohol syndrome. Broad nasal bridge in Fragile X syndrome. Four species in hypothyroidism, mucopolysaccharidosis. Cyanothris in Cornelia de Lange syndrome, cretinism. Cyanothris is union of the ibis in the middle. Okay. Next is hypopigmented fine hair seen in homocystinuria, phenylketonuria, hypothyroidism. Friable tufted hair in minky kinky disease. Alopecia with eczematous rash is seen in phenylketonuria, biotinidase deficiency. Large pinna is seen in Fragile X syndrome. Malformed pinna can be seen in Fletcher Collins and Charge syndrome. Webbed neck is seen in Turner syndrome. So this is the image showing sign of this. This is an example of hypertelorism. Okay, this is clinodactyly. That is curving of the little finger. This is an example of a cherry red spot. Next, broad thumb and toe. Seen in Rubinstein-Davy syndrome. Clinodactyly and simian trees can be seen in Down syndrome. Polydactyly is more than 5 fingers or more than 5 toes, seen in Lawrence-Moon-Biddle syndrome. Syndactyly is seen in Apert and Rosen syndrome. Hypogonadism is seen in Prader-Willi. Macroarthritism is seen in Fragile X syndrome. In eye abnormalities like cataract, seen in Torch infections, galactosemia, cocaine and Lowy syndrome. Corneal clouding is seen in mucopolysaccharidosis. Lens dislocation is seen in homocystinuria, sulfate oxidase deficiency, cherry red spot seen in Tay-Sachs disease, GM1 gangliosidosis, and sialidosis, chorioretinitis scar seen in Tarch infection, retinitis pigmentosa in Lawrence-Moon-Biddle syndrome, cocaine syndrome, and mitochondrial disorders. So let us see some example of the above abnormalities. So this is the image showing lens dislocation. This is of corneal clouding, and the last one is of child with congenital cataract. Which is seen as a white reflex in the pupil. Then what is the above image? This already mentioned as creeping on stairs. It is seen in 15 months of age. Then after taking a proper history, we have to do a detailed examination, mainly focusing on the CNS. So we have to see whether assess the dexterity of the child, like by asking the child to kick a ball or throw a ball, whether the child is able to hop on one foot. Comprehension, it is understanding. That you give a three-step command and observe whether the child is able to perform the command you say. Next is language milestone. Take some common objects and see whether the child is able to name the common objects. Next, whether the child is able to name the body parts, identify the shapes and the colors. Then in cognition, we have to check whether the child is able to identify the object is big or small, or who is tall or short. And whether if you take a box, whether it is open or closed, and also assess whether the child is able to follow the commands. Next is gross motor milestones. Observe for the ascent or the descent of the stairs. Whether the child is doing hopping, jumping, and climbing. In fine motor, use of blocks and beats, and ask the child to do draw a mantis. In activities of daily living. Whether the child has any difficulty in brushing, eating, combing, bathing. Whether the child is able to drink from a cup, able to dress or undress. Next is gait. Observe the gait, whether it is a spastic or a ataxic gait. Whether the child is having a waddling or high stepping gait. Observe for any involuntary movements and incoordination. So in this assessment, no one size fits all. It has to be individualized. So what is this milestone? It is showing the image of a baby who is running. Okay. So it is attained at 18 months of age. Next, after taking a proper history and performing a proper CNS examination, we will move to step one of investigations. So in step one, we will perform a thyroid profile, random blood sugar or a fasting and a postprandial blood sugar, liver function and renal function test, uric acid, creatine phosphokinase. Creatine phosphokinase in muscle dystrophies, myopathies. Okay. Next is serum ferritin, vitamin B12 levels to identify malnutrition. Then we have to do an ophthalmological evaluation whether the child is having any corneal clouding, any cataract, congenital cataract, retinitis pigmentosa. So we have to find the observe for the following findings and do a hearing evaluation to rule out deaf mutism. Next is step two. In step two, we have to focus our investigation to identify the specific etiology which is suspected. We have to look for any neurocutaneous syndrome, chromosomal disorder, any genetic syndrome and metabolic disorders. Based on this, specific tests have to be carried out. Next is FMR1 testing. So it is FMR is seen to rule out Fragile X. Okay, Fragile X messenger ribonucleoprotein 1. It is the full form of FMR1. So the prevalence is approximately 1 in 5,000 births. Causes moderate intellectual disability in boys and variable phenotype in girls. So up to 5 years, we term as global developmental delay, and after 5 years, we use the term as intellectual disability. It is recommended. So this FMR1 testing is recommended for children with moderate to severe global developmental delay. And siblings of the Fragile X patients are at greater risk to be symptomatic or carriers. Should also be screened. The yield for this testing is 2.6%. Next is MECP2 gene testing. It is done to rule out Rett syndrome. So the prevalence of Rett syndrome is 1 in 10,000, 1 to 3 per 10,000 live births. After Down syndrome, Rett syndrome is believed to be the most common cause of mental subnormality in females. and it is an unexplained moderate to severe mental retardation in females. So insufficient evidence exists to recommend testing in females with milder phenotypes or males with moderate to severe delay. This is step 3. So in a child with moderate to severe developmental delay and also a female, you have to do consider MIC-P2 testing. In mild and either gender, you have to do FMR1 testing. Whereas in all severities and grades, karyotyping and fluorescent in situ hybridization has to be done. Next is molecular karyotyping. So new molecular techniques like chromosomal microarray is done to assess the subtelomeric chromosomal rearrangements are to be considered. More than 80% of the chromosomal aberrations found in intellectual disability, developmental delay, or autism spectrum disorders are submicroscopic and not detected by classical cytogenetic methods. The yield in this molecular karyotyping is 15 to 20%, whereas in conventional is only 3%. Microsomal chromosomal microarray. It is the first array investigation for global developmental delay. We are not able to find any other etiological indicators from the history and examination. So this microarray test, it will not detect balanced translocations, being translocation, inversions, low level mosaicism. So hence, standard karyotyping is still required. The utility of the chromosomal microarray in the detection of copy number variants in 106 patients with unexplained intellectual disability or developmental delay, dysmorphism with or without multiple congenital anomalies. So pathogenic CNVs were found in 15 patients. So what is the child doing? The child is turning pages of a book. So when does the child normally turn pages of a book? At 1 year, the child will turn 2 pages at a time. At 2 years, he will be able to turn 1 page at a time. Next is step 4. In step 4, we'll do neuroimaging, in which MRI brain is more sensitive than CT brain. Okay. These abnormalities are found in 40 to 50% of children with global developmental delay. The diagnostic yield is more if the child is having any abnormal findings like microcephaly, focal neurological signs, associated comorbidities like epilepsy. Next is MR spectroscopy. So, in this, we see the level of neurotransmitters emitted by several neurological tissues. In that, choline peak. Choline peak is seen in brain tumors due to increased membrane turnover. And in AA, it is seen in brain tumors. There is a loss of neural tissue leading to reduced NAAP. N-acetyl acetoacetate, this is the full form of NAA. Last step is metabolic screening. Okay, in that we'll see serum amino acids, acyl carnitine profile, uric organic acids, serum lactate, pyruvate, ammonia and CSF lactate, serum isoelectric focusing, plasma very long chain fatty acids, 5-folic acid and phytanic acid, serum 7 dehydrocholesterol. Next is blood and skin fibroblasts to rule out lysosomal enzyme deficiencies, CSF neurotransmitters. Metabolic screening. Routine screening for IEM, which is inborn errors of metabolism, has only a yield of about 1%. In particular populations, if there are clinical indicators are also associated, it can increase up to 5%. With stepwise screening, when stepwise screening is performed, the yield increases to 14%. So some IEM are treatable. Okay, but it can replace with do enzyme replacement therapy. Cut some make some changes in the diet. Next is creatine deficiency syndromes, mild homocystinuria, female OTC deficiency, initially present as global developmental delay alone. So those smaller numbers, since they are treatable, it is to be considered in all patients with GDD of unknown etiology. So to summarize, we can diagnose a developmental delay From the history and examination alone, in one third of the diagnosis can be made, and one third can be made by the lab investigations. And to confirm a diagnosis, okay, by history and examination. This is one third, and etiology will be unidentified. And each child is an individual. There is a wide range for when a child achieves a particular milestone. Always listen to the parents and perform a thorough history and clinical examination. Remember the red flag signs. So it could be a time consuming and labor intensive process. So we have to have a pragmatic and a practical approach. Investigate and interpret the results appropriately, and we have to follow a multidisciplinary approach. And each medical encounter is an opportunity to review development. So to summarize in total, so what is developmental delay? Delay is a developmental delay is delay in more than two domains or more than two standard deviations below the mean. So it could be syndromic or non-syndromic. Syndromic means associated with any CNS malformation, syndromic features, facial features. Non-syndromic could be any isolated features. Isolated means developmental delay in any particular milestone, like commonly see a speech delay. Okay. So to identify a child with developmental delay, we have to know the common normal developmental milestones. So only I have inserted the images in between. So once again, we'll recall the red flag signs. A male child who is not walking independently by 18 months, early handedness by 12 months, excessively floppy or excessively stiff, having early head control or opistotonic posturing. Okay, when the tone is increased, the child will develop head control earlier and have an abnormal posture. Abnormal startle reflex, walking on toes and oversighing, seen in myopathies. Instant movement disorder in any child less than 1 year of age. So we have to remember the warning signs in each of the developmental domains. Like in the physical, it could be not head control not attained, does not bring objects to mouth, and does not reach for object. The child does not roll over in a 7 months old child. In 9 months, a child can't sit on his own. 1 year old child, the child can't crawl or stand with support. 18 months, the child can't walk independently. And then the cognitive, the child does not point towards object or does not show or gestures. The 2 years child not following instructions, does not imitate. Okay. These are some social and the language milestones. Socialist child does not have social smile, does not make any sound, shows no affection for caregivers, is not interested in mirror play or peekaboo, no back and forth gestures. So after taking up a proper so whenever a child is brought in with developmental delay, we have to take a proper history. Starting from the, we have to elaborate the history, what all domains are to identify, what all the domains are affected. Next, we have to identify for the red flag signs as I have already mentioned. And apart from that, we have to calculate the developmental quotient and take a proper history on the above mentioned points, like from starting from the antenatal period, like history of any comorbidities, history of any tox infections, any exposure to radiation, any drugs, okay, whether during the delivery time, whether any complications were there. Any in the postnatal period, whether the child received any phototherapy for neonatal jaundice, and many routine newborn screening tests like hearing screening and biochemical tests were performed. And in the family history, asked for consanguineous or non-consanguineous marriage. Any previous siblings affected with developmental delay. History of abortions, sudden infant death syndrome. Okay, history of any abnormal on examination, asked for any abnormal color, odor of the urine. Okay, any chronic illnesses in the child and psychosocial deprivation. Also consider asking history regarding autism spectrum disorders, which can be poor eye contact, solitary play, repetitive play, likeness for sameness, and inappropriate social interaction. Examine rule out comorbid conditions also like seizures, the vision difficulties, squint and nystagmus, any hearing deficit, feeding difficulty, and behavioral disturbances, and perform a detailed examination. Okay, and consider the And is investigation in 5 steps. With step one being routine, basic blood investigations like this, LFT, RFT, thyroid function test, and perform a hearing and after evaluation. The step two, if you have identified specific etiologies, perform etiology specific tests. Next move on to genetic testing like FMR1 testing and McP2 testing in Rett syndrome, where there is classical history of developmental regression. Okay. Next is, and we have to in concise to be told, this McP2 testing is done in moderate to severe, mild and either gender consider FMR1 testing, and all severities and grades consider karyotyping and FISH. And last is neuroimaging and with the MRI brain and MR spectroscopy, and consider metabolic screening like TMS, GCMS, and elevate and also perform serum amino acids, urine organic acids testing also. Thank you.